I'm a registered nurse and still have my registration. My background is actually in critical care and vascular nursing, but then I've moved and I've been working with the TENA brand now for just shy of 16 years. Nothing like my colleague though. Sarah, do you want to introduce yourself?
Yes, hiya. So I'm Sarah. I'm a clinical consultant working for ST with the TENA brand. I've worked for ST for a long time. I've actually done 25 years this year. So I've certainly been around a long time. And obviously as a clinical consultant, I'm a registered nurse and love continence and incontinence, strangely enough. So that's me.
I think we're a special breed, aren't we, Sarah? We've worked with this line for so many years, and one of the key things that we want to do with the TENA brand and what we do when we support the NHS trusts with the TENA products and with anyone using any users who are using TENA products is to really emphasize, the best practice and tips and how we can support them. And I think one message that will run throughout this presentation is that incontinence is a symptom of an underlying problem, and it's not normal. So hopefully some of the information that we can share and some of the management tips and things that we'll give you today can help you when you're caring for someone who is suffering from incontinence. Before we go on to our presentation, I am incredibly proud to we've been working with, well, we've just joined a partnership with Carers UK this year. Actually, it's our first year working with them, and I'm working on it, Marie, to organise funding for future years as well, because I think it's a fantastic partnership. And we have had, we launched a campaign called No Love Like It. So before we go through the presentation, I just wanted to show this video to you all on how, say, we as a brand really are looking to support carers. And I'm hoping the sound plays.
Initially, it was quite a shock being told that you've got a disabled daughter. And I reflect now and think, look at what we've got.
I started caring for my mum in 2015. In some ways, it feels like our roles have reversed.
Shortly after I married James, he got MS. I've known him since I was 17. He was the centre of everything and very successful.
Phoebe's got potential like any other. We want her to fulfil her life to the best she can.
It's been tough. She started having these accidents. It's not the body that she's used to.
I do feel lonely sometimes. You've got to keep riding the waves no matter what gets thrown at you.
I often don't feel seen. I'm trying to teach myself to do what I want to do and also be there for my mum.
As a carer, you have to manage that sense of never-endingness.
For me to get an 8-hour sleep would be heaven, but I've still got a 21-year-old that wants a cuddle every night. It's very special. There's no joy like this.
There's no pain like this.
No, there isn't any love like this.
So yeah, so we've been so proud of this, and we're really sharing this video and sharing all the posts linked to it to really raise the profile of you guys essentially, and the work that you're doing and the care that you're putting in, because say the country would not manage without it. You are an underrepresented group, so we're here to help. So what we're planning on doing today is not doing that again. We're going to split the day up into 2 parts, or not the day, just the hour. I'm not going to have you for the full day. So the first part I'm going to hand over very shortly to Sarah, and we're really going to be looking at some of the myths linked to incontinence. There's a lot of stigma and a lot of assumptions when it comes to incontinence, and I think it's quite good just to actually put them in perspective and actually put some facts forward on what behind them. We'll look at what is actual a healthy bladder and bowel, because that's always a good start before we look at what potential problems will be. And then we'll go through the different types and causes of incontinence and the symptoms of those. And then we'll also look at some of the other consequences of incontinence, in particular with the skin and how that links. we'll give you an opportunity to have some questions because there's quite a bit of information, and obviously we can follow up on some of the questions at the end of the session too, and give some other information if there's some that we need to give you later. But part 2, we're looking more about the management. So we've got some quite helpful tips, we hope, for you when you're managing or caring for somebody who has incontinence. We'll highlight some support and some signposts and some good areas for you to visit to get some additional information. And then we'll look at some of the incontinence products. I mean, I have got TENA products on here, but just looking at basically some of the principles behind how the products work, how the incontinence products work, and fitting and just selecting, etc. So I'm now going to hand over to Sarah.
Thank you, Ashley. I hope I've unmuted myself, because that's always the first thing we need to do, isn't it? And just to echo what Ashley said, and to say thank you all for coming and for taking time out of your days to kind of spend some time with us, and hopefully it will be a useful session and you will gain something from it. Love to answer any of your questions that you've got, and also just to say how amazing we think you are, really. Certainly personally, I've done some work in the background around sort of carers, how many carers there are, and how many hours people are caring for their loved ones. I'm a carer myself, certainly not to the degree a lot of you will be caring, but I do have some caring responsibilities, and it's hard, and we appreciate that. So thank you for finding the time and turning up. It's much appreciated. So as Ashley said, we'll start with kind of a question really as to what comes to your mind when you think about incontinence. And really, what do other people think, or what do you think other people think when you use, or when we say the word incontinence? We know what people experiencing incontinence think, because they will tell us, and we've, we spend time doing training sessions and asking this question of sort of people, what do you think? But if you kind of try and imagine somebody who hasn't come across it before, what do they think about incontinence? What are the words that come to mind? And if you want to pop any of the words into the chat, I'll come back to this in a few slides, and just kind of see some of the words or the ideas that come to mind when we talk about incontinence. I don't want to preempt anything, but I don't imagine that there's an awful lot, I think a lot of the words that will come through, or the things that people will associate with incontinence, are going to be more negative than positive, unless you're me, because as I've already mentioned, love incontinence. So I think already Ashley's talked that we're going to look at some of the basics of how our bladders and bowel worked, but I think even taking it back a little bit further, for people like myself, and to I'm sure some extent yourselves, that are kind of it's a daily thing that you're talking about, it's something that you think of on a daily basis and consider and are probably having to manage on a daily basis. We kind of take for granted that everybody knows what incontinence is, everybody knows what a bladder is, everybody knows what their bowels are. And so we'll talk about urinary incontinence and fecal incontinence, and we have lots of medical definitions as to what it is. But at its most basic, I think it's worth not presuming that people actually understand when somebody might mention a district nurse or a doctor or a GP, and have you had any incontinence, that not everybody really knows what we're talking about, what we're meaning. And so at its most basic, urinary incontinence is leaking urine, passing urine without having that control over it. And fecal incontinence is a little bit of a broader term, because that will cover not just the leaking of feces, but also mucus, or even just wind. Sometimes people will call that flatus. And the other thing that always strikes me when we think about definitions, and when we talk about urinary incontinence and fecal incontinence, the terminology that we're using, we need to make sure that people understand it, that it's their terminology. We talk about feces, we might talk about stools, and they're not words that probably the average person would come into contact with or use on a regular basis. And so sometimes we almost have to remind ourselves, take a step back and not shy away from using the words like wee and poo, because that's what we're talking about, and we all do it, and most of us know those words. But yeah, it's just I suppose it's just bearing in mind how the person that you're looking after, how the person you're caring for, how an individual refers to their own bodily functions, and working within that rather than trying to put our definitions around it. We know, one of the things that we know, and I'm sure you can testify to much more than myself, that urinary incontinence can impact on people's quality of life in so many different ways. It's a really individual thing to experience, both as the person experiencing incontinence and the person or the people looking after you, the people that are caring for that person, for your loved one. Excuse me. And we know that it's very difficult to talk about. Sorry, excuse me. I did mention earlier that as soon as I start to do anything like this, I develop this need to constantly clear my throat, and I do apologise about that. So there's so many different ways it can affect someone's quality of life. So we know that people who are incontinent tend to have more falls, they tend to be on more medication, and very often will have a larger number of what we would call comorbidities, but other health-related problems or disorders. Very likely that their sleep is disturbed, and then consequently, if you're caring for somebody who's incontinent, your sleep is also going to be disturbed. And there is a social stigma, rightly or wrongly there is. I think we'll come on to talk around some of the myths around incontinence on the next slide. But I think for most people, there is an association or a personal hygiene and self-esteem problem that's really difficult to talk about. Very often people will have a fear of odours, a fear of leakage, and embarrassment is the most common word that comes up when we talk about, as I did earlier, what do we think about when we hear the word incontinence? Excuse me. And then if you are managing that incontinence, even if you're managing it really well using products, you've got to be able to change those products. You've got to be able to dispose of those products. You might feel like you need to be near a toilet, or at least know where the toilets are, and heaven forbid your Marks and Spencer's toilet is closed for some work, or, you know, people very often have these very rigid routines that they have had to put in place just to manage their incontinence. So I'm just realising, actually, Ashley, I've not been asking you to move on, have I? Oh, you've kept up with me. Fabulous. Sorry. I can't, because I can't see very well when I've got my slides up. So going back to that first question, I can see, because I've now come off my screen that's on, that there have been some things put into the chat. So Ashley or Mari, if you'd like to shout out a couple of those that have come up.
Yeah, we've had quite a few things. So lots of laundry, distressing, embarrassment, puddles on the floor, cleaning the floor, constant changing, causes infections, indignity, dirty, lots of washing, care homes that smell, bladder control, challenging, loss of dignity.
Yeah, and as I said, that they're not amazingly positive, and no one's going to sit here and say it's easy. It is a really difficult thing as an individual to accept, and very often as a carer, it just takes everything to another level. And so when we see a myth like I don't know anyone with incontinence, it's kind of quite startling. And when you think of the impacts that it's having on people, you start to realise then the lengths that people are going to hide that fact. So you can see the figures there that 1 in 10 people may have a problem with fecal incontinence, and that's a large amount. I don't know how many are on this call, but you know, it's quite a large number, 1 in 10, if you kind of project that. And I think the thing that I always take from this myth, that I don't know anyone with incontinence, is what I said earlier, the lengths people will go to hide it. There are people out there that are suffering from incontinence that you will have no idea about. And so it's getting that openness and talking about it. Like a lot of things, just because we don't see it doesn't mean it's not happening. And the next myth is incontinence only affects the elderly. And actually, if you click on the next, whoops. So you can see some of the age ranges. Sorry, I do apologise for this cough. You can see some of the age ranges there. So 1 in 3 women over the age of 35, and is it 1 in, I can't see my screen now, 1 in, you'll see on the next one actually, 1 in 4 men over the age of 40. So it doesn't affect only the elderly. It's no respecter of age, it's no respecter of gender, it's no respecter of social class, wealth. It can happen to anybody and it can affect anybody. And when we see those figures, so we've gone from 1 in 10 to 1 in 3 to 1 in 4, it just makes you realise how common it is. Some of the problems that we have with knowing exactly how common it is going back to that stigma, the embarrassment. Not everybody will seek help. So if we're looking in people's medical records to see how many people are suffering from incontinence, we're missing a massive chunk, a massive kind of group of people who don't want to seek help because of fear of embarrassment. And if we're asking people, again, the chances are we're missing some people out, a section there who really don't feel comfortable disclosing the fact that they are incontinent. So those figures are our best guess, but realistically, we really don't know how many people are suffering from incontinence. The next myth, that drinking less fluid is how to control urinary incontinence. And we do come across this an awful lot. And you can see why. The less I drink, the less I'll need to go to the toilet. You know, I've, in our previous, my previous life, as it were, before COVID, we would do an awful lot of travelling. We would be supporting customers. I live in Manchester, so all over the northwest. And I was the worst for not drinking during the day, because if I drank, it meant I had to stop and find a service station or something, and I'd have to go to the toilet, which took me 10-15 minutes. And when I had to get back before nursery closed to pick up the kids, or, you know, for whatever reason, or get to my next call, I didn't have time to do it. So it makes sense, the less we drink, the less we'll need to go to the toilet. But actually, particularly as we age, we know that that's not the case. And most types of incontinence will probably be worse if we're not drinking enough. Our bladders will become irritated by that very concentrated urine. And then the last one there is that incontinence needs bad hygiene. And I think, again, and I sometimes worry that I get a little bit too plain speaking, or a little bit too, I don't want to upset anybody. But, you know, most of us probably will have been in situations where we've perhaps been behind somebody in a queue, sat on a bus, or, you know, just out and about, and we've got that whiff, that smell, and we kind of think, oh, I personally, you know, my reaction is, oh, God bless them. I hope they don't realise, because it's not always something people can help. But that myth, that experience that we might have had, kind of perpetuates. It's nothing to do with bad hygiene. It's about having the knowledge and the tools and the products and all the support to manage it properly. If it goes back to those figures. If 1 in 3 women over the age of 35 are experiencing urine leakage, certainly not 1 in 3 women that I walk past do I think, oh, there's one. So we hide it. It's a hidden problem, and certainly that association with bad hygiene and the smells and it's horrible. And, you know, we always used to say, as nurses, when people would ask what you're doing, say nurse, they go, oh, I don't know how you deal with people with poo and things. And most of us as nurses, certainly most of the nurses that work for TENA, but most that I've come across, it's never been as bad as people might think it is. But people have that in their minds, that it's horrible and it's disgusting, and it's not. When you're caring for somebody who is having accidents or suffering from incontinence, you take one look at that person's face, and you certainly soon realise that any kind of smells or any kind of disgust, you need to put that to your back of your mind, because it's nothing compared to what the individual's going through. Next slide, please, Ashley, if you haven't already. So we said we'd look a little bit about how our bladders work, and I'm a great believer in, if we know what something should do, then we know when we need to worry when it's not doing what it should do. And so we've got a diagram there, a very basic diagram of our bladders and how it links in with the rest of our urinary system. So you've got your kidneys at the top, and they're filtering our blood constantly and producing the urine. So pulling out all the sort of excess salts and toxins, sometimes some of the excess medication and the drugs and things out of our blood, and the excess fluid, obviously. Excuse me. And it gets passed down into our bladders, down those tubes called the ureters. The bladder is essentially just a big muscular sac, and I always think of it as like a balloon that's been blown up and deflated and blown up and deflated. So it folds in on itself, and it's just there. It has two functions: to store that urine and then use that muscle power to expel it when we want to go to the toilet. The urethra is the tube that the urine passes through when we are going to the toilet, and supporting all of it is the pelvic floor, and we'll talk a little bit more about pelvic floor when we think about different types of incontinence. But the pelvic floor is a big sling of muscles that runs from the front to the back, and it's supporting everything, it's holding everything in, and making sure that it's in good tone and condition, and consequently sort of losing that tone and condition, like all our muscles do as we get older, is one of the main reasons why people can struggle with incontinence, or start off with maybe not being able to control their bladders as they would like to. So on average, depending on how much fluid we drink, on average we'll pass urine somewhere between 4 and 7 times a day. So that's kind of what we have as these norms. It's considered quite normal to need to get up to go to the toilet once during the night, and as we age, actually that figure increases, so we tend to pass more urine at night as we get older. So it might be 2 or 3 times in a night that somebody needs to pass urine, which, when we mentioned earlier, getting up 2 or 3 times a night just to go to the toilet, I'm not at that point yet, thank goodness, but that's not something to look forward to, really, is it? Having that level of disturbed sleep. And for most adults, when we do pass urine, we'll be passing around 300 to 500 mils, depending again on how much we're drinking, what sort of fluids that we're drinking, which Ashley will talk about later. The one thing that I just want to kind of make a plug for here, really, we talked earlier about drinking enough fluids, and I really can't kind of emphasize how important, especially in this hot weather that's coming up, how important it is to keep pushing fluid through ourselves and the people that we loved for, to make sure that we keep our kidneys working in as good a condition as possible. So what we're looking for is when we're passing urine, my family go mad at me because the amount of times I ask them what colour their wee is and how much poo they've done and what it was like. They just despair with me. But we're looking for getting a nice pale colour, and there's lots of resources out there that help kind of show us what colour should our urine be. But for your health and for the health of the people you look after, being really kidney aware, it's something, as Ashley will know, that I'm really passionate about. And one of the best things that we can do is notice the colour of our urine and drink plenty of fluids to keep those kidneys working. They like to do their job, and if we don't give them enough fluid to pass through, they start to get a bit fed up, get a bit dried and a bit shrivelly, and they don't work as well. And for an older person, it doesn't take very much for that not working as well to kind of to tip over to the sides, where it really can become a health issue and a concern. I'm presuming Ashley is judging by pauses as she's moving on a slide. So a couple of different types that you may have or may not have heard of. Stress incontinence is a bit of a misnomer. It's got nothing to do with how stressed you are, although anxiety can make our incontinence, or certainly our bladder, can change our bladder function, make us feel like we need to go to the toilet more often. But it's more to do with the stress that a full bladder is putting on the pelvic floor, that support sling that we talked about earlier. So as you can see there, the main symptoms are leakage when we're coughing, laughing, sneezing, exercising. It could be as simple as standing up from a chair. It can be, younger people can experience if they're doing very heavy lifting. But the main cause of stress incontinence is childbirth, and the sort of the stress that our pelvic floor is put under when we are delivering children and having babies. It's not exclusively a female condition, and gents can certainly suffer from stress incontinence. They have a pelvic floor in the same way. But generally speaking, if someone has got stress incontinence, it's a frequent loss of very small amounts of urine, maybe 5-10 mils, and so is managed quite easily and quite simply with a small pad, a small sort of product, and also is very easily treatable. We know that in general, the figures are that around about 75% of incontinence could be either cured or significantly improved if we get the right help and advice and treatment programs in place. And certainly stress incontinence is one of those types of incontinence that responds really well to treatment. It's not a quick process, but it certainly does respond very well to treatment. Urge incontinence, and again, I'm sure we've all at some point or other experienced some urgency when we really need to go to the toilet and we need to get there quick. And urgency is by itself is one kind of sensation. Urge incontinence is when that sensation of urgency comes over you with very little or no warning, and before you can almost even register it, urine is passed and the bladder tends to completely empty at that point. So it's larger amounts of urine. It can be very, very unpredictable and very distressing, if you can imagine, as I'm sure you've all got experience of it. You know, very often for some people that start to experience this type of incontinence, it can come from nowhere. So you've not got a little just in case pad on. It's not something that's ever happened before. And it can be really quite distressing and upsetting to be in that situation. When I talked earlier about that bladder being like a balloon that fills and empties, in the wall of our bladder, you can see it labelled there as the detrusor muscle, but within that bladder wall, we've got stretch receptors that pick up when our bladder's getting full. And that's how those messages are going up to our brain, and we feel the sensation we need to go to the toilet. Our brain then sends down a message to say, not the right time, not the right place. And that's quite a constant process that's going on for a lot of the time. And our brains are really clever. They shove that to the background, and we're not always aware of what's going on until there's more urine in the bladder, and then we'll get another, oh yes, I do need to go to the toilet. What we know that in a healthy adult bladder, that starts when the bladder's about half full, about 50% full. So we've got 50% more capacity to go before we need to take any action with that. But those, if you think of a balloon that you keep blowing up and it deflates, you blow up and deflates, it starts to get a little bit saggy, it starts to get a little bit loose. And our bladders do a similar thing. They lose that tone, so that by the time somebody's in their 80s, certainly as we age, that warning that we need to go to the toilet happens a lot later. So an older person can be, somebody in their 80s, their bladder can be 85% full before they get that sensation that they need to go to the toilet. And so instead of those gentle warnings that we all get as it builds up, for an older person, they can experience it very differently. And you can say to them, 1 minute, do you want to go to the toilet? No, I don't. No, fine, I've been sat here, I'm fine. And you can go off, put the dinner on, go outside, go upstairs, go downstairs, put washing on, whatever you want to do. And before you know it, there's a shout, oh, I've wet, I need the toilet, I've wet. And sometimes it feels really frustrating in that, well, I've just asked you and you didn't need to go. I've turned my back and now here you are, you've wet yourself, and it can become really quite frustrating. So just understanding that actually that's not, that is how that person's experiencing it. It's not people not being bothered. It's nothing to do with memory, although those things don't help. It is actually physiologically how they're kind of experiencing it. Can make us perhaps, can help us to deal with it and to put, I want to say tactics, but I don't mean strategies is the word I mean. Strategies in place. If you know that somebody hasn't been to the toilet for 2 or 3 hours, asking them, and you know that in the past you've asked them and then they go straight away. Sometimes it's not about asking, it's just about encouraging and taking. I hope I'm making sense as I'm going along. I'm sure Ashley will tell me if I'm not. And then the last type of incontinence we're going to look at in this section is functional incontinence. And that's really where somebody will have a bladder that functions normally, or they may have a bit of urge incontinence and they may have some stress incontinence, But what's making them, what's kind of taking it from a situation that they can cope and manage with into becoming more of a problem or an issue, are other environmental factors or physical challenges that don't actually affect the bladder. So you can see things like dementia or confusion, mobility, and not just sort of an individual's mobility, but the environment, the home environment that they're in, perhaps. It can be something as simple as pain relief, and we know that very often, particularly people with dementia, once they start getting the dementia and are unable to speak for themselves, very often they don't get the same sort of levels of pain relief as people without dementia. If someone's had arthritis before they had dementia, they're still going to have arthritis when they've got dementia. And so those things making it a little bit more difficult to get people to the toilet, to get up and to do all those things very often in a short space of time, can mean that people will develop this, what we call functional incontinence. And very often with functional incontinence, it's where we kind of get to the point where people need to manage. If we can't put any strategies in place, bring toilets downstairs, adding grab rails, make maybe the clothing easier to take off, potentially using bottles and things like that, then very often that's where we end up having to use something like pads just to manage the incontinence. I hope I'm all right for time. If I'm not, please, I've only got a few more to go through, but if I'm not, Ashley, please give me a shout.
It's okay. Well, yeah, we're a little bit over, but keep going.
I'll be very quick. Sorry about that. So looking a little bit then at the bowel, you can see there just a couple of things about what would be normal for bowel function. Everybody is different, and so those 3 times a day or 3 times a week are the kind of extremities. So if you normally go twice a day, then that's normal for you, that's fine. Very often referring to the stool charts, so those pictures of the different types of stool or poo that we pass, can be quite useful. I think the most important thing with bowels and bowels habits for yourself or for those that you're looking after is know what's normal for you, and if anything feels out of the ordinary, then that's when you need to be kind of potentially getting some, seeking some advice, or certainly letting GPs or district nurses, your healthcare practitioners know that there might be something a little bit different there. Sorry, I didn't mean to click on that. Causes of fecal incontinence are wide. There can be lots of different causes. Again, you can have functional fecal incontinence where actually, particularly if somebody is having care visits, or you need to wait for those care visits to be able to help the person you're looking after get onto a toilet, they don't always line up exactly with when somebody might need to open their bowels. One of the biggest causes is constipation. As you can imagine, if sort of stools are getting loaded up into our bowels, into the rectum at the bottom, that constant pressure to open our bowels to pass those poos out into the toilet can cause marking on underwear or on pads, and eventually, if the person becomes so constipated and never actually clears that blockage, then they can get sort of the looser feces at the top leaking out past it. So many causes, but generally fecal incontinence is a little bit more of a challenge to manage because of the odours and the discomfort that go along with it.
Sarah, can I just jump in on that as well? And there is such a link between constipation and your urinary function. So they are all really interlinked. So if you are, if someone is suffering from constipation and you've got that large stool or whatever mass in the abdomen, it can push onto the bladder, so it can make the urinary incontinence a lot worse. So when assessments are done by the continence service, which we'll talk about later, they will always look at, well, what is your bowel pattern, and what is because if they can fix the constipation, then actually your urinary function could improve dramatically. And actually, I think it's fact, isn't it? Constipation is the most common reason why children are incontinent of urine.
Yeah, so, it does have a massive impact, and it doesn't. I think the thing, it doesn't just impact on their urinary incontinence. It can cause confusion. It can cause headaches. It can cause general malaise. It can, it can really affect an individual massively.
And that's the soapbox I have. When I used to go around all the care homes delivering training, that was the thing, because bowels just do get ignored. And, looking at bowel patterns are incredibly important.
They are, and I think, sorry.
I said I wouldn't heckle, didn't I? I'll be quiet.
It's fine. I think once you started, I think the other thing is, I can remember, we can all tell so many stories, but I remember quite clearly going to a hospital ward with a gentleman who was using pads, and the staff was sort of complaining that they were having to change these pads too frequently. He wasn't really cooperative. He couldn't really communicate because it was constantly soiled. There was constantly a mark on the pad, and because the gentleman was incontinent, the staff had not made the connection with, okay, he's incontinent, but we still need to sit him on the toilet. And I was with a continence specialist nurse, and he'd been in for about 4 days, and she said, what were his bowels like? And they all looked a bit kind of shocked and blank, and we sat him on the toilet while he was there. He had an absolutely massive poo, and they just hadn't sat him on the toilet because he was incontinent. So sometimes it's about sort of making sure that the other people that are coming in that are helping have those same priorities, and make sure just because you're incontinent of urine doesn't mean you can't sit on a toilet. You can, and it's important. So just very quickly about sort of skin related problems, I think very often managing somebody's incontinence is hard enough, but then if they are getting sore, if they are getting irritated, we refer to it very often as incontinence associated dermatitis, or IAD, but you also hear people calling it moisture associated skin damage. So anything really in that area caused by the incontinence, the urine, or the presence of urine or the feces on the skin. You can see some of the causes on this slide here. The first two we can't really do anything about. If somebody's incontinent, then there will be moisture from urine. There will also be probably a little bit of increased sweating because you're wearing a product. And if they're fecally incontinent, those enzymes and the irritants are potentially going to get against the skin. There's not really anything we can do. But the last three are things that it's definitely worth thinking about and making sure we're doing everything we can. Cleansing with soap and water, that repeated rubbing of the skin can take away those very delicate top layers. Soap can be quite harsh and drying on the skin as well, and if we don't rinse it properly, then again that can cause issues with irritation. Making sure we're lifting people and moving people properly, and that they're in the right incontinence products. Ashley's going to talk about those, so I will stop, but I think the only thing I would say about this is that it's people sometimes will think that any kind of irritation or soreness is down to bad care, or a pad that's been left on too long, or something that we've done that we could have prevented. It is preventable if we have the right routines and we have access to the right products, but with the best will in the world, it's not. You can't exclude it completely. And if we make sure, if we know what we're doing, or if you know what you're doing, and using, like say, the right products, cleansing gently, you're doing all you can to prevent this happening. So it isn't an indication of that a pad's been left on too long, and it isn't an indication of bad care. It isn't an indication that somebody hasn't been washed or hasn't been cleaned. It's unfortunately a risk that a lot of people suffering from incontinence will have, and we do our best to mitigate it best we can, but certainly it's not something that anybody should ever feel, oh, I've left that pad on for too long. Generally speaking, it's other things that are causing the reaction. And I think that's me. I'm sorry I went on.
It was great. Should we do questions, or yeah?
We've had a couple in the chat.
Okay.
One, is it possible to re-strengthen lax female pelvic floor when older, 60 plus, via exercises?
Yes. Absolutely. Sorry, I know we said we're going to take it in turns, but absolutely, there's no limit. And you will, continence professionals that we speak to will quite often say they've had an 80-year-old in, and it's always best to get help and advice so that you're doing it properly. It takes a long time, but absolutely, it's not to do with the age as such. It's sticking to it, practicing it, and knowing where you're starting from. Particularly as we get older, making sure that you have got that tone there in the first place, that you're doing the exercises properly. But absolutely. No.
When you were presenting the myth slide, Sarah, I think something that jumped out at me as another common myth that we hear all the time is that it's just one of those things that happens as you get older. Incontinence is you just got to accept it, and you shouldn't. No, age is, if you introduce the right treatments, you can, stop it and reverse it. It's just making sure that you have the support there and that you review correctly.
Thanks.
Any
and
other
just one more in the chat. You mentioned it's really important to drink lots of water, and you said 6 to 8 glasses per day. Someone's asked, what kind of size glass are you talking about?
We tend to say, oh, am I? We tend to say you're looking about, I'm going on metric here, so you're looking about 1,500 mils. But it really does depend on the weather and in the situation, and also and the size. But if you're getting 1.5 litres into 2 litres, that's great. When it gets hotter, you need a lot more. Because you're losing a lot more through sweat, etc. So
I do think, as I said, looking at the colour of your urine is the best indicator.
And we've got a good image soon in the next section to show you.
Great.
I might leave that one to you, Sarah, to present, since you're so passionate about the colour of
no,
wheat.
if you want to get more quickly, don't leave me on mute.
Thanks. That's it for the questions in the chat for now.
Okay.
Does anyone else have any?
Yeah, so are there any other questions?
All good.
All good. Cool. Okay. So the first obvious question is, well, what can we do? If we're caring for someone with incontinence, what can we do? And the first thing, and we have it on our adverts now, and we have it on our packs, and as I said before, it's a symptom. It's something else that's happening and that needs to be reviewed. So we would always advocate, if yourselves or you're caring for someone who develops incontinence, or they have incontinence and the conditions gets worse, then really they need to have a medical review. It could be that the medication needs to be reviewed. It could be that looking at the actual say the care that's being delivered, are there better toileting routines that can be done? Do they need different products? Don't accept it. If the skin starts to become inflamed, they need to be reviewed. Do they need additional cleansing products or barrier products? So seeking that medical advice is really, really incredibly important. All the NHS trusts have continence services. You can, I'm not sure whether any is already dealing with continence services. I'm hopeful that you are. They will review, you can self-refer, or you can get referrals through the GP. And that is basically, some people will call it as the pad provision service. They're not. They're there to actually resolve the incontinence and to see what treatment options can be introduced to improve the problem. If they can't improve the problem, then of course, then they will look at providing incontinence products, and that's but that's all linked to the various trusts and their provision criteria. But this is the first step. As I say, I would always go to them and speak to them for some advice on how to improve the situation, the symptoms. There are lots of charities and advice lines. We work very closely with a charity called Bladder and Bowel UK. They have advice lines that you can phone, and they have a whole host of different products available that they can talk to you about and give you some advice on. And of course, accessing a radar key, having trying to manage products or toileting when you're out and about, access to toilets can be a challenge, and if you want, having access to those disabled toilets by using that radar key, then can make the situation a lot easier. So there's lots of other little aids that you can get from the different charities as well. So as I say, I do really recommend that you reach out. When you're looking at tips of maintaining a healthy bladder and bowel, well, the first thing, as I say, I went on my soapbox a lot every time I was doing training, was looking at your diet, making sure they have a balanced diet. Obviously including that fibre in the intake if they are able to eat fibre. Obviously, I know some people will have restricted diets that we need to be aware of. looking at the fluid intake myself, got to do a nice image next. Making sure that the toilets are private. Certainly if you have patients where we are looking at dementia, having those kind of facilities where they, just because they may be more confused, you'll find that the memories can regress, and having that nice environment, that private environment, can make a difference to them, and they may be more accustomed to using the toilet facilities. And I mean, I will touch on it actually at the end about maybe some of the topics, and we can look more into managing continence with dementia in one of the other topics if that's an interest. Looking at toilet visits. Now, it says we encourage regular toilet visits. One thing I will say is we want to steer away from that just in case we as well. It used to be, any time that we would do anything, we would always go, and I mean, my gran always used to say, spend a penny. And what you can do by doing that is literally, if you're emptying your bladder all the time, you're losing that flexibility of that balloon that Sarah mentioned before, and it can mean that the capacity of the bladder can drop down, so you're having that lower volume. So there is a balance here. Yes, you need to encourage people if they're not able to actually feel that their bladder is filling, then you maybe prompting and encouraging that way is important. But going to the toilet every hour or every half an hour just in case can be detrimental to the way the bladder functions as well. So is that careful balance. We would say 4 to 7 times a day is on average the normal functioning of a bladder or emptying of a bladder. Now, the toileting position is another one I'd say is, I was focused on bowels. And this can make a huge difference to somebody opening their bowels. The new conventional, it's not new now, but the conventional toilet, and especially if you're using raised toilet seats as well, can really put the positioning of the bowel completely out of sync. We're basically designed to open our bowels in a crouching position in the woods. Obviously, we're not doing it now, but that's how our bodies are formed. So if where our knees are higher than our hips, the bowel will actually straighten, and you can get a really good passage of stool through. So we find that if you're hosting patients, moving patients around in hospitals, they will actually tend to open their bowels in that position because you're really elevating their knees. So one solution to that, if you do have raised toilet seats, is when the person you're caring for is on the toilet, on the seat, you can introduce like a footstool or something, and that will actually increase the knees and put them into a better position so they're able to bear down. Another thing, I mean, we've got the gastrocolic reflex here, and this is taking advantage of there's just natural responses that the body has. And this is basically something that can occur once you eat. So often with breakfast, as soon as food hits the stomach, then that will actually stimulate the bowel to empty. So we can really introduce that when we're caring for people. Give them that nice big breakfast. Don't clean them before breakfast. Give them the breakfast. Get them onto the toilet in a really good position. You may find that they'll then open their bowels properly in the toilet, and then you can obviously get them cleaned and get them dressed, etc., and carry on the day. If they don't have a proper motion in the toilet, what can often happen is the stool is still there, and as Sarah said, it'll just keep coming out in little bits all through the day, and that can obviously have a detrimental effect to the skin condition, and also increases the risk of infection as well. So if you can get a proper motion in the toilet, it can make a big difference, and it can make the person feel so much better as well. Review the medication I've already touched on, and regular exercise that can really help with the food transition going through the bowel, the gut. What's the term? I've forgotten the term now. But anyway, pushing the food through. Gut motility, isn't it? That's the word, isn't it? That's the word. Yes. Are they drinking enough? So this is the chart that Sarah mentioned, and a lot of areas will have them all around on the back of doors and things, especially if you go in health centres. But it is key, we should be aiming for 1 to 2. Well, it's been cut off, that one, look. It's not a very good slide, is it? But you can see it's very pale pale and transparent, pretty much clear. And when you start getting down into these kind of areas, you really are not drinking enough, and you can have some serious health issues because of that. What are they drinking? I know I keep drinking. I have to assure you, I'm not, you can't see, I'm not drinking gin. This is water. I keep taking the sip and I'm thinking, I look like I'm sipping away at my gin and tonic starting the weekend early, but it's water. But yes, you really need to make sure that they are drinking the right fluids. So obviously water is the best fluid. Be careful with caffeinated beverages. That can really, that's been found to actually increase overactivity in the bladder. So if they're already susceptible to some sort of irritation of the bladder, overactivity, that can be problematic. So we need to try and steer away from those as much as possible. Unfortunately, alcohol as well is not a great fluid to be drinking if you, you know, put your bladder and bowel, to avoid those. So as I say, we'll just go on the products. So there are many different products available. I mean, I've got just a few examples here on this slide, and obviously there's a lot of different suppliers that produce products as well. I'm not saying go out and buy TENA, please don't take this message, but what we do mean is that because of the huge range, you need to be really aware of how you would select the products and what's going to be most suitable. So there's a few different aspects to when you're selecting a product and how you choose. The first is, you know, when we have like it's like 9 different criteria when we're looking at a patient, down to, you know, how mobile the person is, whether they're actually being cared for, obviously the level of incontinence that they have, how much urine are they passing, what size are they, you know, because we have lots of different sizes to the products. And there's a lot of information on the different websites. I mean, we have a lot of information as well. I'll show you shortly on our site to guide you through that product selector. So you can put in the different sizes, and there's a lot of customer services as well for the different suppliers that can guide you through selecting a product. One of the big things though that we find is around about the correctly fitted. You know, if you pad, they're not magic, and sometimes we see pads where, especially the two-piece systems where there's a pad and a net knicker, if they're not fitted correctly, they will leak. You know, they're designed, and some of our pads will hold 1,300 mils. Well, some of them, the all-in-ones, will hold even more. You know, that's a significant amount of fluid. If you think what a person is drinking in, you know, they're drinking in around about 1.5 litres to 2 litres. So it's unlikely that they're going to be passing out more than what they're actually drinking in, unless they're actually giving that medication to really push the fluid out. So fitting is really, really important, and making sure that they have that right size. The way the products work, so they have something in it, they have pulp. So sometimes you'll see products that are really thick and you think they're going to be really absorbent, but the pulp is a bit like cotton wool. So when the product when the moisture hits that pulp, if you squeeze it, the moisture will actually come back out of the product. The absorbency in the pad is really these polymers here. These polymers here. Can you see that mouse on there? Oh, that works. I could have been pointing ages ago, couldn't I? But these are like magic sugar granules, and that when the water hits it, they turn into a bit to gel, basically. I don't know whether anyone's washed any pads before, and you've probably seen them in the washer, but they really clump up and they swell so much fluid. So it's the sap that actually is the absorbent aspect of the pad. And so some pads you can come across that are fecal pads, so they don't actually have any of that sap in the product at all. They've just got that cotton wool, the pulp, so they have a very low absorbency. But then you'll come across other products, and I know there is a increasing drive with our TENA range is to be as discreet as possible and get them as thin as we possibly can, because what we're doing is we're adding in more and more of the sap and more of the technology to actually protect that patient. So you will see that some products that you buy can be a lot thinner, but they still have that same absorbency. That's just a technology within the product. They have wetness indicators. Some range have wetness indicators on the back, and that will actually tell you how full the pad's getting. So on our lines, they change blue, and what we're looking on generally, it's 3/4 of the line to be blue if you're looking at an all-in-one product, or both the front and the back indicator on a shape product to be blue, that you know that it's reached its working absorbency. And the working absorbency of the product is basically how much urine we think that should hold in practice before it needs to be changed. So some quick do's and don'ts. I'm conscious. We are going to run over. Is that okay, Marie? Yeah, that's fine. I'm so sorry. I blame Sarah. So some quick do's and don'ts. Obviously, complete an individualized product assessment. Now, we work with healthcare professionals, day in, day out, and we've actually just generated some really powerful research from key opinion leaders, like looking at having that bespoke continence assessment, introducing a treatment plan that matches that individual's needs. We shouldn't, just using one product across the board for everybody. It just doesn't work. We have to make sure that the patient's needs are looked at and the pad's given appropriately. Pads should always be body worn. Don't lie somebody on a pad or sit someone on a pad. And that's because of the way the pads are constructed. They need to be fitted closely to the skin for them to work effectively. I've already mentioned the wetness indicators. Another good tip is when you're looking at the products, don't put them in moist environments. So sometimes we see them stored in like shower rooms or bathrooms. And that humid environment, or actually some care homes will put them in sheds outside as well, which we don't recommend. But that moisture in the air can actually start reacting with the products, and it can cause them to be less efficient or less effective. So yeah, be mindful. And what we do say is that because we're trying to save and be as sustainable as possible, so the pads now are very much, well, certainly all of ours are vacuum packed, so we can get more into a smaller space. So what we say is you get them out of the packets, in advance, like for the day, so that they can actually start to free up, to relax, and then that will actually help with the acquisition of the urine, so the urine will enter easier. Don't double pad. Now, when people are having issues with their and leakages, that seems to be a common thing that people will do, or they will buy smaller ones to go inside a larger pad. Now, all the products are pretty much, well, I mean, even like with inserts, we would be really mindful of their use, because what will happen is if you've got a smaller pad inside a bigger pad, the small pad is designed to hold so much urine. And then, yes, you may be lucky, and I've seen carers actually put holes in the back of the back sheet so that they think the moisture will drain through into the bottom pad. But what will happen is the pad against the skin will overfill. And then that's going to, because when it's overfilled, that's when the urine will start coming back out of the pad and start affecting the skin condition. So the pads are designed to hold as much urine as we would recommend. We don't want them to overfill, because then you're going to get, skin's going to start breaking down. Bed pads, I don't know whether everyone's seen this. Some people use puppy pads as well to protect the beds. That's what they're doing. They're protecting the beds. They're not protecting the patient. And as I'm going back to what I said in the first tip is, if you're finding that there's a lot of leakage, don't accept it. You're the person you're caring for is going to be at risk. You need to look at why that is the case, what can be changed. But the bed pads are just protecting the beds, and they can get wet and they can start affecting the patient's skin. So be really careful with that. But I know I'm really conscious that laundry was one of the key things that came up many times when the questions that you're saying about incontinence. And it is, it's a huge task caring for someone with incontinence. And so I know why they're being used, but just beware, they are protecting the bedding and not the patient. Talcum powder, I don't know whether that's used as much, but we do. We used to see it sprinkled on top of the pads, because they, I think when the terry nappies were used as well, it's almost like a freshening. But what you're doing is literally affecting that top layer of the product, and you're clogging the pad up, so the urine won't enter the pad as easily. So we really would say stay away from talcum powder completely, ideally. And it's the same with barrier creams as well. All the guidance with barrier creams is use it as it's directed, so sparingly. And I've seen some really thick creams applied incredibly thickly to the skin, and then people will apply it onto the pad as well to be just in case, to make sure. But again, it's basically you're creating a waterproof barrier on top of that pad that stops the urine going into it, so you're defeating the product of having the pad in place. So other things to consider, just like when you're looking at the environment, as we're saying about functional incontinence, is the toilet easy to find? Again, this links in with dementia as well. It can be really confusing for an individual if they're not in an environment that they're familiar with or that they remember. So sometimes, certainly in care homes, we really encourage the use of signage. Are they using mobility aids? Would that be helpful? Some additional, if they are struggling to mobilize to the toilet, are there other aids that can be made available? I know for some gentlemen, one big challenge is spraying. They don't have a steady stream, so and you can get funnels that actually help direct the stream of urine into the toilet, so that can help with cleaning and just the practicalities of managing their urination. Looking at clothing, I think Sarah's already mentioned that. Looking at say introducing anything to help them with the toileting position. Trying to do a bladder diary is another good tip as well. I mean, you would be encouraged when you see the continence service, when you're doing a continence assessment, a bladder input or bladder diary is part of that assessment process. But sometimes it's good just to see if there are any patterns. As Sarah said, if you ask somebody that they need the toilet and they said no, they don't feel that they need, and then you go a bit later and they're wet, well, if that's a regular pattern, then I would be always saying, well, can we toilet them then? Has a UTI been excluded? That will always give you frequency if they have a UTI, and that's possibly one of the main reasons why, if somebody suddenly deteriorates, I would always be looking at getting a sample of urine if possible from that person and checking. Dipsticking the urine, and I'm hoping that clinicians aren't just doing that these days, but it has been found that your bladder will have a natural colonization of bacteria in there anyway. So if you dipstick it, you can pick up a false positive. So we would the guidance is that sample should be sent to see if it is actually there is an infection there, and then what antibiotic would be helpful rather than just giving a broad spectrum one. Has constipation been excluded as well, which I've talked about before. So how to maintain good skin? I think just to recap here, obviously toileting is the best. The more that hits the toilet, the better it is for skin health. Making sure that they have the most appropriate product, and as I say, there's a lot of ranges out there. If one, and it could be, for one supplier of products that you say, you may find that one of our TENA products doesn't suit, but a competitor's product has a different template and a different fitting style, and therefore you get less leaks, and vice versa. So don't think, or you don't accept leaks, is basically what I'm saying. Look at these actual products that you're cleansing the skin with. There's a lot of products now available on the market that are designed to be used with for incontinence, like non-rinse cleansers, so they will really help protect the skin. And look at the barriers, and sometimes the NHS will be able to provide those for you. And Sarah's already said avoid harsh soaps, because that can really strip the natural oil, the sebum that's on the skin. The soaps can strip that off, and it can make the skin quite dry. And be mindful of overhydrating this, washing after each episode of urinary incontinence or incontinence can be detrimental to the skin condition. So using those non-rinse cleansers can help a lot. So just really quickly, I'm almost finished. I'm sorry we're running over a bit. I just want to show you this very quick video because there are new products coming in the market, again, from other suppliers as well as ourselves. So I just want to play this little video for you.
The TENA Smart Care Change Indicator takes the guesswork out of caring for someone with incontinence. The indicator attaches to the incontinence product your loved one wears and tracks its moisture level. When it's time to consider a change, it sends a notification to your phone. Then it's easy to switch over and reset on a new product. Your loved one experiences fewer disturbances from unnecessary checks, and it also reduces leaks and supports their skin health by helping them stay dry. Care information can also be shared across friends and family, making it easier for them to help out. The change indicator means more dignity and comfort for your loved one, and more peace of mind for you.
So this is a very new device that we have literally just launched in the UK in March. So because they were working with Carers UK, we were given the opportunity. So if anybody does want to actually try the device for free and be willing to link in with us to give us some feedback, then this is available to you. So there's a QR code there just to get us some details from you. And then I'll be in touch to see if give you a bit more information about the product and if you would like to try it. But it's to say it's free. There's no charge to it. We just want to get some additional feedback from you. But these are new products that are coming in, and it is the future. And we've got some other products that we're launching with health professionals as well to help with assessment. It is everything evolves, and it's looking at and looking forward. So say the technology in the products is developing across the board, and then this is just another example of how we're trying to improve care efficiencies for you. That sounds very corporate and professional, doesn't it? I'm sorry. It's nice being able to actually present. I haven't actually done any delivery of education in so long, have I, Sarah? Am I doing okay? Yeah, all right, thank you. And just some last little bits. So we do, as I mentioned before, we have a website it's just TENA.co.uk. And on there's a whole section here for family carers. So there's a lot of articles on there about supporting patients with incontinence, and more tips and guidance on this. There's a whole wealth of information there. And we also have a Facebook page called TENA Carer. And that again has some useful guides in there, and we share some different information about products, and so that's all available for you. And that is my last slide, I think. So it's like, so thank you so much. I'm sorry we've overrun by 15 minutes. It's bad, isn't it? But has anyone got any questions or anything for us?